And welcome everybody. Welcome Hayley. We are ready to go as I've just admitted our participants from the lobby. Thank you.
Oh, thank you, Adrian. Prynhawn da pawb, croeso. Hayley Thomas dwi, Prif Weithredwr Bwrdd Iechyd Addysgu Powys. Diolch yn fawr iawn i chi gyd am ymuno â ni heddiw. Bydd ein Gweminar yn cynnwys cyflwyniad wrtha i a hefyd Kate Wright, cyfarwyddwr meddygol ein Bwrdd Iechyd, ac yna bydd cyfle i ni ateb cwestiynau. Cyn i ni ddechrau, byddai'n gofyn i Adrian Osborne i roi cyflwyniad technegol byr i ni. So, good afternoon all, welcome and thank you very much for joining us today. I'm Hayley Thomas, Chief Executive of Powys Teaching Health Board. Our webinar today will include a presentation from myself and Kate Wright, the Health Board's Medical Director, and there will be an opportunity also to answer questions. But before we begin, I'd like to ask Adrian Osborne to provide a brief technical introduction.
Thank you very much, Hayley. So, Tab, if we can move to the next slide. Today's webinar will be recorded so that people who are not able to join us live can watch the webinar later. We will publish the video on our engagement website after the event, and you'll see the website address for that at the bottom of all of our slides today. And we'll also publish a copy of these slides on the website as well, so the information in front of you will be available for you to peruse at a later date. Now, we're using Microsoft Teams for today's event. If you see 3 dots on your screen, you will see language and speech options, and that enables you to turn on live captions if you wish to increase the accessibility of today's event. And our webinar will begin with a short presentation, and as Hayley said, that will be followed by a Q&A session. And you should see a Q&A button on your screen as well, and you can use that to post questions to our panel today. We welcome questions in both English and Welsh. Now, please do accept our apologies if during today's webinar we're not able to answer all of the questions raised with us today, but we will keep our engagement website updated with the latest FAQs. There is a further webinar happening next week as well. Recognise we have some members of staff who've joined us here today as well, and there's a further internal staff briefing taking place next week too. So without further ado, I'll pass you back to Hayley Thomas to begin our webinar.
Thank you, Adrian. So I'll start with some facts and figures about Powys Teaching Health Board. So we're the body responsible for providing and commissioning health services for the population of Powys, about 133,000 people. All of us who live or work here will know some of the challenges we face in Powys. The county spans 2,000 square miles, a quarter of the landmass of Wales, and in fact it is the most sparsely populated county in England and Wales. People in Powys live longer, which is a good thing, in good health than the average for Wales and the UK average. However, there are inequalities within our county. For example, Powys is at the forefront of an increasingly older population, with 28% over 65 years of age. This means that more people are living longer with increasing ill health, multiple conditions, and there is growing demand for health and care services. Also, a third of people live alone, and we know loneliness can increase ill health and is a key reason why people seek help from healthcare services and the wider sector, including the third sector. We all know that there are some major challenges facing us in healthcare. Waiting times for planned care increased during the COVID pandemic and remain too long, and people are spending too long in hospital. An extended stay in hospital can lead to deconditioning, involving losing muscle strength and disorientation. And this can make it even more difficult for people to return to their previous level of independence after a hospital stay. And this further increases the likelihood of readmission to hospital. We also face, generally in the NHS and particularly in Powys, recruitment challenges, and that's exacerbated by our rurality. These challenges not only affect the Health Board, but the wider system and social care, which makes it more difficult to support people to leave hospital in a timely fashion. Our ageing population also means that the proportion of people of working age is also reducing. And because Powys is the most sparsely populated county in England and Wales, this does create extra challenge for planning and delivering services. We also know that we face cost of living pressures and inflationary challenges, which affect the way we are providing services and how we access them. So given these challenges, the Health Board is facing significant financial pressure as a result of the increasing prices and inflation, together with increasing demand and the issues that we face with regard to workforce availability. So we need to deal with the facts as they are. In the end of financial year 22-23, we ended the year with a deficit of £7 million. Last year, at the end of the financial year 23-24, we ended the year with a deficit of 12 million, and we currently expect that we will end this year, 24-25, with a financial deficit of 22.9 million. We know that this cannot be achieved in a single year, and therefore our plan that we've submitted to Welsh Government sets out how we will move towards a break-even position over the next few years. There are three main reasons or areas where our costs are growing significantly. The amount we spend buying healthcare services for us from neighbouring district general hospitals and other providers is increasing, and costs have grown by 36 million over the last 5 years. That's a 27% increase. The amount we need to spend on agency staff to help keep services running and keep them safe has more than doubled in the last 5 years, and again is a substantial concern. And the costs also of providing continuing healthcare have also more than doubled, increasing by 16 million over the last 5 years. The increases are significantly higher than the uplift in the funding we've received. Despite the cost improvements we've already made, and I can reassure you that we are focusing very hard on all aspects, including administrative, corporate and management costs, we do continue to operate with a deficit position. And Welsh Government has recently written to us again to ask that we make further plans to reduce our deficit position this year. I'd now like to ask Kate Wright, our Health Board's Medical Director, to come in. Thanks.
Thank you, Hayley. So we're often asked why we don't have a district general hospital in Powys and why we have no accident and emergency or emergency department. I think there are several reasons for this. To summarise, the population size, we have a small population. Our geography, it makes it very challenging. The fragility of services that the whole health service is currently experiencing, especially around staffing, is significant. And really importantly, then whilst people do frequently require hospital care, we know that providing care at home is increasingly important, and there is an increasing move to provide as much care as possible within people's own homes. We know that outcomes can be better, and so there is a move away from inpatient hospital treatment wherever possible, and that is certainly part of our ethos. So just to explore that a bit more, then the geography is really important. District general hospitals provide urgent and emergency care to patients, as well as what we call elective or planned care. For emergency care and urgent care, people will naturally go to the nearest hospital, and that's important in terms of travel times. For a large part of our population, then that would mean that their nearest emergency department or nearest district general hospital would be one of the hospitals outside of Powys. So our challenge would be where to put a district general hospital, and wherever we put it, we would find that people would naturally travel to other sites because they were much closer. That would lead a small number of patients who were actually accessing an urgent care service within a district general hospital in Powys. That would really lead to an unsustainable service. The fragility of the health service is widely understood, and even at times, if we look back to times when we'd had easier staffing and found recruitment and retention easier for staff, then even then it would have been very, very hard to staff additional district general health services. To run a district general hospital, an emergency department is key, and whilst there are varying models, then there are also several key support services such as medicine, acute medicine, surgery that requires anaesthetists and anaesthetics, maternity units and paediatrics. With any one of those services becoming fragile, a district general hospital becomes significantly fragile and raises significant safety concerns. So putting all this information together, I hope that explains why not only, I think there were two questions, could Powys have a district general hospital? And I think the answer is no. And should Powys have a district general hospital? I think for the reasons we've outlined, especially given people's proximity to other sites and the difficulty of where one would be, and the issues with fragility and difficulties with staffing, then I think that it is something that wouldn't happen. That doesn't mean that we're not ambitious in terms of the care we provide, and we really are ambitious to provide as much care, both in terms of planned care and urgent care, as close to people's homes as we possibly can, and that is absolutely our ethos. So the reason for sharing this slide is to emphasise that every day we as a health board are trying to keep many different factors in careful balance. We aim to provide and commission services in the best way to meet your needs and expectations. Alongside this, we need to make sure that those services meet quality and safety requirements, that they deliver the outcomes, importantly, that we need for our patients, and that we can staff them appropriately. And alongside this, we must operate with the resources available to us. That's not just the money, but also the people, buildings, and the way we work in partnership with the council, the third sector, and the wider health and care system. Given these challenges, the Health Board has put in place a work programme to identify temporary changes that can improve quality and value. Two areas have been agreed for wider staff and public engagement, and they are the minor injury units and inpatient wards. We're looking at other areas and we'll keep you updated as the work progresses. So we are looking at some temporary changes to the minor injury units, and from the 1st of September 2024, we'll be making changes to the opening hours of the minor injuries units on a temporary basis, as the slide indicates. So the hours in Welshpool and Ystrad are unchanged. The hours at Landard and Brecon will change to match Welshpool. That is, they'll be open from 8 to 8, 7 days a week. It's important to explain why what minor injuries units do and don't do. They're not there for life and limb threatening injuries. It's really important that people who have significant and serious injuries dial 999 or go to A&E for those injuries. The nature of the injuries that a minor injury unit can treat means that they can wait until the unit is open the next day with very minimal risk. For example, through use of home first aid for a cut and painkillers for any pain. Self-care advice for common conditions is available from NHS 111 Wales website by ringing 111 if you don't have access to the internet. In many towns in Powys, a minor injury service is provided by your local GP practice, and that's available during the hours that a GP practice is open. In Brecon, Landard, Welshpool and Ystrad there's a minor injuries unit provided directly by the Health Board. It has additional services that aren't available in the GP practice, including X-ray. But X-ray is not available for all the opening hours of the MIU, and in the evening and overnight, patients will be asked to come back the following day for an X-ray. And in a number of situations, their injury may need more immediate attention at a major hospital A&E department, although we know that's uncommon. Later in the presentation, we'll share more information about the number of people who attend our minor injuries units. So Why are we making changes to the minor injuries unit service in Powys? Well, they face several challenges. On average, our minor injuries units in Brecon and Ladod see just 1 or 2 people per night. That's not good use of the public resources or especially skills of the emergency nurse practitioners who provide the services. Nearly all the patients who attend overnight could or should attend during the day. For example, we're not able to offer a 24-hour X-ray service, so patients needing an X-ray need to come back the following day. It's difficult to recruit and retain sufficient EMPs, emergency nurse practitioners, to run the service in the current opening hours. And because we can't always find staff with the right skills, we sometimes need to close a minor injuries unit at short notice. It's a growing problem, and between January and May this year, there were over 50 occasions when a Powys minor injuries unit needed to close in the evening or overnight because of staffing issues. That means that we're not able to provide a reliable service. So we've looked carefully at the number of people attending our MIUs. The information on this slide is an average across the year, but we've looked at the data based on different days of the week and across different seasons of the year. You can see that we have an average of 25 patients per day in Brecon between the hours of 8 and 8 p.m, and an average of 1.4 patients outside of these hours. I should emphasise that that's the number of patients per night and not per hour. We've looked in depth at the needs of the patients who have visited our MIUs in Brecon and Ladod overnight. Most could safely wait until the unit is open the next day. We recognise that this offers less convenience than now, but minor injuries units treat low to moderate risk injuries, and home first aid will help manage the injury until the next unit is open. Some patients already need to be asked to come back the next day. For example, they need an X-ray, and the X-ray services are so low overnight that it wouldn't make and is not cost effective to have or even possible to recruit the X-ray staff to take the X-ray, so it can't be undertaken by MIU nurses. In a very few cases, patients need to be referred to A&E because their conditions can't be looked after in an MIU. A call to 111 gives 24-hour access to urgent care advice. The patient would be directed straight to A&E, saving an unneeded visit to MIU. For example, during 2023-24, less than 1 patient per week was referred overnight from a Powys MIU to an A&E department. If the MIU wasn't open to if the MIU was not open, these patients would go straight to A&E based on advice from 111, and again, that would save them a trip to MIU. So we've identified opportunities for temporary changes so that the service is safer and more reliable. Offering more reliable opening hours and reduce the time of unplanned closures is better for everybody. No lone working out of hours. That's safer for staff and safer for patients. Encourage more people to phone first wherever possible. That means that our specially trained nurses can assess your needs over the phone, provide advice on first aid and self-care, and book a slot that's convenient for you or direct you to a more appropriate service. It enables us to redirect and redeploy some staffing to other vacancies or high-cost agency spend areas. And it allows greater opportunity for cross-cover between the MIUs, which is a healthy way to work. We'll also be making some changes to the overall staffing model to better match the needs and demand. For example, on the previous slide, I mentioned that on average, Ustragunlai sees 7 patients per day or 1 patient an hour. Across our MIUs, we need a better fit between the level of demand and the level of staffing. The second area where we're making temporary changes are inpatient wards. We expect these temporary changes to be in place for 6 months while we keep them under review and continue our planning for the longer-term shape of health services. 2 hospital wards will be designated as our ready-to-go-home units. These will provide focused care and support for people who are ready to return home but waiting for a package of community care. They will be located at Llanidloes Community Hospital and Broncleys Community Hospital. 2 hospital wards have an enhanced specialist role to support patients who require inpatient rehabilitation. These will build on the existing arrangements for stroke rehabilitation. So they'll be located at Brecon War Memorial Hospital and Montgomery County Infirmary in Newtown. Our other wards and centres continue as now. Overall, this means that we'll have the same number of beds in the same locations as now. And overall, in Powys, we will continue to care for the same caseloads of patients in these beds, although the location where some people receive their inpatient care will change compared to now. We need to address a number of challenges. Firstly, in relation to patient quality and outcomes. Patients are spending longer in community hospitals than they should. One reason is because they're waiting for packages of care in the community to support them to go home, including a care home. We know that if people spend too long in hospital bed, it can lead to deconditioning. They lose their muscle strength, their ability to care for themselves, and also become disorientated. This makes it harder for them to return home, and it can increase the likelihood of readmission to hospital or of them becoming unwell during that hospital admission. We need to break the cycle and support people to go home as quickly as possible. Specialist staffing. The rural nature of Powys means that our specialist skills are spread thinly across the county. There are benefits in bringing patients with the same needs together and in concentrating our specialist staff in these locations rather than skilled staff spending a lot of time travelling between different hospitals. Finance. In common with other services, we face challenges in recruiting and retaining skilled staff. We have a high dependency on agency staff, which is extremely expensive for the public purse. The plan changes should reduce our reliance on who, in addition to being more expensive, are often unfamiliar with the wards and the patients, and potentially this leads to reduced quality of care. We've identified opportunities for temporary changes so that the service offers better quality and value. It better design the model of care around patients' needs, specifically designing sites as ready to go home units, design sites for patients needing rehabilitation, building on the existing arrangements for stroke rehabilitation. This means that more patients will be in an environment better focused on their care needs, but will also mean that the local community hospital will not always be the default for patients. I'll now hand back to Hayley. Thanks, Hayley.
Thanks, Kate. In terms of next steps then, so our period of engagement aims to raise awareness of the changes that Kate has just outlined and the reasons for them. And we're planning in September then to bring these into place. We're continuing to develop ideas that help us deliver safe care within the resources available to us, and we do welcome your ideas. I also wanted to reassure that we will always keep these temporary changes under review. Later this autumn, we also want to work with you to continue our learning about the temporary changes we're putting into place, and also to help shape the safe and sustainable future of health services in the county. Alongside today's webinar, there is more information about these temporary changes on our engagement website, and the address is there on your screen. So this brings me to the end of our presentation, and now I'll hand back to you, Adrian, so that we can pick up any questions from the audience. Thanks.
Diolch o galon, Hayley and Kate. Thank you very much, Hayley and Kate, for that presentation. So now we're going to turn to the questions that have been raised with us today, and I recognise that some of our colleagues provided questions in advance. Please do use the Q&A opportunity within today's briefing in order to raise any questions that you have, as I'll be using the Q&A panel in order to bring in the comments and questions that people have raised. So first of all, we've received a number of questions in there about issues that are more about specific staffing and internal matters. Now, mentioned at the beginning that we have some events going on for staff over the next few weeks. This event day is focused on public and external stakeholders. So with those internal briefings underway for staff, as well as the direct engagement with the staff who are most impacted by those temporary changes, those questions that some of our own staff are raising would be better addressed through that. Next question here for Kate. You talked about Phone First. I think one thing to emphasise there in response to a question is we do strongly encourage that where people can use it, and because that does help ensure that we're able to offer people an assessment of their needs before they attend. But also equally, we do recognise that Phone First isn't possible for everybody. So if the phone isn't an option for you, then walk-in does continue to remain available at our MIUs now and in future. But somebody has asked whether this affects ShopDoc in Brecon, and I think that question could apply to all sites, Kate. So in relation to ShopDoc, is there any impact that we've identified here?
Thanks for that question, Adrian. So the answer is no. ShopDoc will continue to operate along its current sites, and so that service won't change. We know that the number of patients that do present to us overnight is very, very small, as we've indicated, and we've looked at where the workload and where they may present. So given all of that and given the conversations with ShopDoc, then there is no concern that it will have an impact on ShopDoc, and the overnight service from ShopDoc won't change.
Thanks, Kate. And if I can stick with you there as well, number of questions here really asking, is this an improvement or not? As medical director, what's your view on that?
Thanks. I think that's a really important question. So I'm aware that it may seem as though a lot of this is about finance, and whilst that is important, for me, what's absolutely key is quality of care and outcomes for patients. And so I think it's really important that the driver for these changes has been that we know that there are big opportunities to start to provide improved care. And we can probably give a couple of examples. We know that at the moment we have a significant number of patients waiting outside of county to come back, having had an admission to a district general hospital outside of the county. They're waiting out of county to come back into Powys. And that is difficult given the length of stay in our current system in our own community beds. It can be very difficult to bring them back into county. We expect this will improve the flow through our hospital beds, and we therefore expect that we will be able to bring patients who are stuck in other counties back. We know that sometimes those patients actually end up being placed in longer term placements because people can't come back to Powys. So we see that for those patients, then the care will improve. We know that when we opened, we began our rehab service in Newtown, I think it was around 2014. Then at that point, the rehab offer for our stroke patients improved significantly. And that is a good example of how cohorting the patients together can improve the quality of care by focusing those highly skilled staff with the patients that need them most. That's not to say we won't provide rehab services for everybody else, but we learned from previous practice, but by cohorting patients, we saw an improvement of care, and we'd expect to see a similar improvement by further increasing the cohorting of our rehab patients on those sites. But it's something we're watching very carefully. I think those are just two examples, but I think there are many examples of how we could see care improve as we improve the processes and flow across our system.
Thanks very much, Kate. I've got a question here next to it, which I think, Hayley, I'll direct towards you, if that's okay. So people are asking us, these changes focus on frontline services, but what about admin and management?
Thanks, Adrian. Again, an important question. We've been relentlessly focusing on corporate admin and management back office costs as an organisation. And to be frank, these changes often are not noticed by patients. It's something that we do as part of our internal management of the organisation. Unfortunately, the scale of the financial challenges that we're facing means that in addition to this, we need to find a way to deliver frontline care in a more sustainable and safe way. So these temporary changes will help us stabilise these services for today, whilst we also need to have a discussion with yourselves, with our staff, with wider partners and stakeholders and the public about what the future needs to look like.
Thanks very much, Hayley. And thinking about that, this is an engagement on temporary change. Are these changes truly temporary? Do you think this is reversible, for instance?
Thanks, Adrian. This has been a really important point. A number of people have been asking me personally. The reason we set this for a 6-month temporary period is because whilst we're undertaking these changes, we've made a commitment to evaluate, learn and review and to test that these are having the impact that we're looking for the outcomes for our patients. So they're definitely reversible. The beds are still in place, same number of beds. The minor injury units will still be in place. And clearly the broader conversation then that we'll be having in the autumn about the future shape of future services is definitely not predetermined, because we will need to have those discussions and take the learning from these temporary changes into account when we look at the options for the future.
Okay, but will community hospitals close? Is this downgrading by stealth?
I'd like to reiterate that these are temporary changes, but I'm also under no illusion about the challenges that we face as a health service right now, and that's facing all of us who use and work in it. As Chief Executive, my key role alongside the board is to ensure that we take our responsibilities very seriously to make sure that the NHS provision in Powys is fit for the future. And the NHS marked its 75th birthday last year, for example. Lots of community events, huge passion and commitment from our communities and staff. But we need to think about how do we make it fit for purpose for its 100th birthday. So, you know, together we will need to look at all of those options and potentially not shirk potentially difficult decisions. But, you know, for example, some of the issues that we're facing demographically around the population, we'll have to think about how do we plan a service to respond to that, but not just as a health board, but across the whole system.
Thanks, Hayley. And you've talked there about keeping this under review. I've had a number of questions here about sort of, well, how are they being monitored? What are your evaluation criteria? How will you make those decisions about either making them permanent or returning to the current model?
Yeah, thank you. Really important question. And we're hearing from staff, clinicians, the feedback we're hearing from the public and key stakeholders. We will need to make sure that that robust approach to evaluation and review is in place, and that actually we share that in the public domain. But perhaps you'd like to come in here, Kate, about the approach we're taking to evaluation. Thanks.
Yeah, thanks, Hayley. So we're going to be looking at a wide range of measures, including length of stay, patient experience and concerns, and the reduction in delays of bringing people back into Powys, as we discussed previously. We know that there's increasing evidence in terms of harm from delayed discharge, and that's something that we all want to improve on. So I think those are going to be the main measures, but we will be learning as we go. I think some of the questions that we're listening to people during the engagement process, and I think there'll be important measures that we may add as we go as well. But I think those will be the key ones, because for me, those are the ones that actually are probably causing the most harm in our system at the moment.
Okay, thanks, Kate. I'm just looking through the questions I've got here in the panel. There's a number that broadly focus on the financial situation. And Hayley, why is the financial situation bad? Why is it getting worse? And bluntly, as somebody's asked, why can't the government give us in Powys more money to tackle this?
Okay, so well, firstly, I mentioned earlier about the growing demand on services. That coupled with inflationary pressures, have been major factors around the increasing deficit position for us. And we've had big increases in costs as well around buying hospital services. Mentioned to you earlier that we've paying that has increased by 36 million over the last 5 years. And the costs of continuing healthcare and of agency staffing, 2 examples there, have more than doubled. So yes, we've also got energy costs, the price of medicines, the price of new treatments. So these all have a cumulative impact on our financial position. And clearly the fact that we moved from 12 million last financial year to a forecast of over 20 million this year reflects that. But, I was asked the question, if we were given by government an extra 25 million, these changes wouldn't be required. And I think you've heard clearly from Kate's presentation and detail, we've got broader issues here around the sustainability and our ability to staff safely some of these services with the current model as well. So we would still need to be looking at the future model to make sure it's fit for purpose for the future. I think the other issue is for us in terms of taking action here, that as we proceed with this work, it is important for us to take action as early as possible, because every day that goes by, unfortunately, without our ability to get a better model in place, will store up even bigger problems for us to solve.
Thanks. And there's just an interesting follow-up question there. Somebody asking whether we pay for each person who attends an out-of-county A&E and MIU. And just to put that into context, if the overall amount that we spent last year was sort of just over £400 million, that included that deficit position that you described there. About half of that overall money is what we spend on hospital and other healthcare services from hospitals in neighbouring health board areas and in England on providing continuing healthcare, funded nursing care, etc. So about £220 million each year is spent on purchasing those healthcare services for Powys residents from other organisations other than ourselves. About £79 million of our budget last year or expenditure was on primary care, including GP services, primary care, high street pharmacies, prescribing, dentists, optometrists. About a quarter of it went on paying for our own staff, including wards, midwives, mental health, learning disabilities, district nursing, therapies, as well as our corporate teams. That's 117 million. And then the remainder, about 30 million, is on sort of clinical supplies, premises, energy, transport, and other non-pay costs. So if that just gives an idea about where that overall expenditure goes to. A number of questions here, just to come back to you, Kate, on which is again, just to really reiterate, why can't we have an A&E in Powys?
So, some of you may know I used to be an A&E consultant, so nobody loves A&E more than I do. But I think it is to be able to run any service. I hope that our ambition is great. And my ambition is to build services in Powys. My ambition is to do more and treat more people. And I think there is definitely opportunity to do that. But what we have to do to do that, the only way we can do that and to do that responsibly, we have to do it safely and sustainably. And so to run an emergency department requires so many support services. Even the very large hospitals are sadly currently struggling with fragility. So in the current environment, we would not be able to staff an emergency department or the support services that it would require to be able to do it safely, even in the short term, but definitely not sustainably, I think. But equally, it wouldn't be right, because the majority or a significant proportion of our population live close to other emergency departments that they would travel to, rather than an emergency department that was put at a position in Powys. Geography just isn't our friend in that respect. So whilst I am really ambitious to make sure we provide as much acute care as we can in Powys, and actually we do provide, our general practitioners are extremely skilled and do provide a lot of urgent care in Powys, then any care we provide has to be safe and sustainable, and that would not be the case if we had any attempt at introducing an emergency department.
Thanks, Kate. I think in many respects I'd echo that, as I've worked in the acute hospital sector for a large part of my career as well, and understand those challenges for delivering safe 24-hour emergency care are very considerable, even when you're working on a much bigger population basis, and the need for all of those clinical specialties to be behind that open front door, so that whoever attends, we've got the clinical skills behind that door to provide them with the best care and the best outcomes. If I can stay with you, Kate, we've got several questions here that I think an issue that's very important to people is having a safe place to die. Palliative and end-of-life care is a big theme in the comments and questions, sharing their own stories with us of how the local community hospital provided a safe local place for their relative to die with their loved ones near at hand, and they're worried that more people will die further from home now as a result of these changes. So any reflections on that you can share?
Absolutely, and absolutely, it's a very, very important part of the work we do. So just to really state, just to reassure that we continue to provide end-of-life and palliative care in Powys. If a patient currently becomes sadly either palliative or end-of-life on our wards, we will support them, and we will try very, very hard not to move them. We will still be able to admit patients end-of-life into Drumfleece and Llanny. If there will be admission criteria, and they will need to meet those admission criteria, but if they do, we will absolutely admit them there. There will be a small number of patients that may need to move to other sites, but again, that will be with a focus on quality of care and providing the best possible care we can.
And discharge from acute hospitals as well, Kate. I mean, a relative here spent a long time in hospital in England before returning to a community hospital in Powys. Do you truly believe that this will help bring people back into Wales, back into Powys quicker? Yeah,
I do. I've, as I said, I've worked in emergency care for most of my career, and I understand the critical importance of getting people home as quickly as possible. And I'm talking days rather than weeks and months, as unfortunately we're currently experiencing. So the first thing, well, there are many, this is one part of it. We've done a huge amount of work looking at improving flow through our system, and it remains challenging. And we have evidence, and we've learnt from systems that have been put up in other areas, that by having focus on discharge and patients focused needing discharge, then that absolutely, there's evidence that will and does improve flow. So we expect to see and hope to see the same in Powys. We work very closely with our surrounding health boards just to make sure our systems and processes are as good as they can be, and that continues. But I have every anticipation that this will improve flow. The evidence supports that, and that will improve or decrease the time that it takes people to get back into our own beds, or indeed, my strong preference would be straight home, and that's what we're all working towards.
Indeed. Now, there are a number of questions here about straight home and the social care capacity within the system. Perhaps I'm just conscious of the time on today's webinar. So there are two questions, maybe more for Hayley, that I'll take today, and we'll do our best to pick up some of those other questions in our next webinar, and also on our website, and in updating our FAQs. Hayley, this one really too about the engagement process. So do you think the Health Board did enough to engage with staff, public, GPs and stakeholders before these plans were published?
Thanks, Adrian. I think it's fair to say that we've had to work at an unprecedented pace with regard to some of these changes. Particularly, we're asked to turn around quickly plans for financial sustainability, and the Health Board still remains in a position without an approved plan for this financial year with Welsh Government. I think the issue is the longer that we take, the bigger the financial challenge risks becoming for us to solve. And therefore, we would potentially have to take even greater action if we don't move at pace. So yes, in answer to your question, I always would prefer to take more time, to have more conversations with more people. But I'm also aware that, you know, the work that's been undertaken to develop these proposals has involved a large number of individuals. They're sound, and we need to refine further during this engagement period based on the feedback that we hear from people about any other issues that we would want to consider to take immediate steps to address. And, you know, clearly we have a duty as a board to put in place a plan to enable us to live within our means. I think the other issue to mention for me is around why this engagement. I appreciate it is the height of summer holidays as well, and we've heard that the timing of this engagement has not been great for that reason. So again, we'd want to encourage people to give us our views, and we will continue to work alongside everyone as we proceed with these temporary changes to look at how and what other ideas people have got about how we can further develop sustainable services.
Thanks. And on the subject of engagement, again, I recognise that some people put hands up. We're using the Q&A panel today to draw the questions to the panel today. So just before we wrap up today's session, Hayley, what impact will this engagement have on the implementation of next steps?
Yeah, all of the insights, information, feedback, views that we're collating them currently, and that composite report of all of the work will be fed back and taken into account fully. The issues that are being raised are really important to our patients, the public and stakeholders, and that will inform how and the way in which we will monitor and evaluate these changes going forward. And in turn, it will also help us to start the work and the longer conversation, engagement and consultation about the future shape of health services in the county. So this engagement is about raising awareness of what is happening and why and how to help us to learn and evaluate what we're doing to inform the longer term model.
Thanks, Hayley. So conscious of time, we'll run over a little bit there, but if you'd like to just make some final comments before we close for today.
Okay, thank you, Adrian. So diolch i chi gyd am ymuno gyda ni heddiw ac am gofyn cwestiynau. I ni'n mynd i wneud yn siŵr fod y fideo o'r webinar ac yr ail webinar sydd yn cael ei gynnal dydd Mercher nesaf yn cael ei roi ar y gwefan. Plis rhannwch y gwybodaeth yn eich cymunedau ac hefyd i ni mynd i gyhoeddi copi o'r sleidiau ar y fideo ac yn cadw y cwestiynau cyffredin i'w diweddaru. So diolch eto am eich cyfraniad. So thank you very much everyone for joining us today and for the questions that you've raised. We will be making sure that the video of today's event and raising awareness of the second webinar that we have next Wednesday are added to our website, and that we are encouraging you to share with colleagues, communities and your organisations. We'll also be publishing a copy of the slides and trying our best to keep the frequently asked questions updated, taking into account maybe the questions that people have raised today, because I can't see them, that we haven't had time to cover. Pick those up.
Thanks, Hayley. I'll definitely be picking those up. We've done our best to cover as many as we can. Recognise that we've got a 45-minute session today and a further one next week, so we'll continue to pick those up through our website and FAQs. But thank you everybody for joining us today, and that brings our webinar today to a close.